And welcome to the Dr. Bob Show. 37 million people in the United States will get a sinus infection every year. Sometimes they're short-lived, sometimes they're chronic, sometimes they respond to medications, sometimes they don't respond to medications, sometimes surgery is needed. Wouldn't it be nice if it was possible to be able to have sinus surgery in the office where you don't have to have general anesthesia and go into an operating room? We'll be talking about that on this show. My guest is Dr. Mark Overholt, board-certified ear, nose, and throat physician. He'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host on the Dr. Bob Show for the next 30 minutes. Later on, we'll be talking about a TIA, a type of brain stroke, and women in cancer. What should they know about cancer and what can they do about it? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Mark Overholt, board-certified ear, nose, and throat physician. We're going to be talking about chronic sinus disease. Mark, welcome to the Dr. Bob Show.
It's great to be back.
Tell me where the sinuses are.
They're paired air-filled structures that live in our face. We have two frontals that are over our eyes, two that are between the eyes that are called the ethmoid sinuses, two in the cheeks that are called the maxillary sinuses, and then in the very center of your head, we have two that are called the sphenoid sinuses.
The purpose of those sinuses?
You know, people postulate that maybe it lightens the head, it gets rid of, what would otherwise be a dense bony mass, but they certainly provide a lot of misery for people.
When people get sinus infection, does the body take care of most of them?
Yes, almost 80% of what we call acute sinus infections are viral, and those are self-limited and go away on their own. And even some bacterial infections in the sinus cavities will be self-limited and will resolve. And I think, we have this question in society and medicine now that asks, do we need to give everybody antibiotics? And for every sniffle, the answer is probably no. And the more that we utilize antibiotics for these acute viral illnesses, the more we select out bacteria that tend to be highly resistant, and we put ourselves in the corner a little bit with regards to medical management.
If an acute sinus infection becomes chronic, how long does it have to be there before we meet the diagnosis? 12 weeks?
Yep, you got it.
And when it's 12 weeks, then what is the approach? You need to find out if there's an underlying cause, such as
allergy, immunologic problems that people have. Do they have anatomic issues like polyps that they make in their nose? And we can begin to sort of stratify loosely these patients out in different groups that are more likely to be managed medically or less likely to be managed medically and will require some sort of procedure. And the lines of that continuum continue to blur because we have new tools that help us treat patients that probably would have been medical patients before, but we may get them off medications with some newer procedures. And the real severe patients, we have some new options treatment-wise that may help us manage those people better and prevent them from having relapses as frequently or as severely as has happened in the past.
To try and keep the patient from having surgery, what medical treatment do you normally give? You try and find out if they've got allergies or if they've got polyps and you take care of that. Do you put them on chronic medications for a period of time?
Absolutely. We don't want to unnecessarily treat people with surgery. So we have our patients who have chronic sinus infections tested for allergy, and then we aggressively manage the allergy. So if their skin tests are positive, then we might say, let's just step back and see what happens with allergy shots over a 6-month to a year period. We treat people with nasal steroids, which is just like putting a steroid on poison ivy. It gets the inflammatory response out of the nose, and we'll see if that will open the sinuses up, allow them to ventilate. We treat with intranasal antihistamine sprays or oral antihistamines to manage the weepy, congested, stuffy characteristic of an allergic nose. And then we'll put people on a prolonged antibiotic therapy and sometimes different antibiotics to see if indeed an antibiotic will clear them and get them back to their baseline. And it's those patients that fail that type of aggressive medical management that ultimately need something more.
Now, when they need something more, we talk about sinus surgery. I see a lot of patients that had sinus surgery back in the 1980s, and they say the worst part of the surgery was after the surgery when they had to have packs removed and they had black eyes. Is that something of the old that we don't see anymore?
I think that's something of days gone by. Most contemporary sinus surgeons now don't pack the nose, don't put splints in, and so while the general consensus in the population, the community is that I'm going to have the packing because my grandfather had it. Really, that's not the case. And for patients that don't have the packing, and don't have the splints, you can have a complete sinus operation and septoplasty to open the nose up. If they don't have to have that packing and those splints, really the pain is not much of the recovery process. It becomes more of a congested, stuffy recovery for a few weeks. Most patients who are in this circumstance are stuffy and congested to begin with, and so for them, postponing gratification for a few weeks is not a huge deal.
And the gratification they get is correction of their problem that they've got. Let's talk about some of the newer surgery. I want to talk about endoscopic sinus surgery. What does that mean, and how is that a benefit from the old surgery?
So in the 70s and 80s, we did surgery with a nasal speculum, something that would just distend the nostril, and we looked with a headlight. And they would open up the sinuses below, and the floor of the nostril, had to do some bone breaking to get there. It was a rougher recovery, more blood, more packing, and as we began to develop fiber optic scopes that we use in almost every field of medicine now, it allows us to be less invasive. And so in an endoscopic sinus surgery, the scope will go in the nose and it will project an image onto a TV screen so it's blown up and large and easy for us to see fine detail. And it allows us to get into the areas where the sinuses functionally work. And so we can augment the system the way it was meant to work, rather than creating drainage pathways like a drain pipe.
Now, there's a drainage area where all the sinuses drain into. You call it the
osteomeatal unit or osteomeatal complex.
That unit, if it gets blocked, that's where part of the problem frequently is. Does the endoscopic sinus surgery open up that osteomeatal unit?
It does. It'll take us right to that area. It's sort of the terminal common plumbing channel. And when you see a CT scan on a patient with chronic infection, you can see a soft tissue swelling or plug in that area that blocks it. And in those patients that have that, it's unlikely that they're going to respond to medical management. So we can slip in with the telescope, open that area up, reestablish normal ventilation and drainage, and most people's recurring cycle of infection or chronic infection can be broken in that technique.
Now, when you do the endoscopic sinus surgery, what's the recovery like?
Most patients that have a standard endoscopic sinus surgery will wake up with a little burning in their nose that will last for a few hours, and then for the most part, people don't have pain afterwards, just congestion. I'll say the exception would be those people that have migraine headaches. Sometimes mucking around the nose will trigger migraine, but generally speaking, it's a stuffy recovery.
Medications after surgery, you have to keep treating patient?
Yeah, most patients will be on a nasal steroid, nasal saline. There's controversy about the impact of antibiotics after a sinus operation, whether they're really needed. I think most physicians do put their patients post-operatively on antibiotics, but we're recognizing really that many patients probably don't have to have an antibiotic after a sinus operation. There's not yet that paradigm shift in treatment amongst most physicians because I don't think they have the faith that that is indeed the case, but really the procedure should fix it.
Hello, I'm Dr. Bob Overholt, here to encourage you and your family to get out and play in our Knoxville area parks. Knoxville has dozens of parks and more than 85 miles of trails. There are picnic shelters, ball fields, tennis courts, and disc golf courses, dog parks, fishing ponds, and skateboard parks, trails for hiking and mountain biking, boat rentals, you name it, Knoxville has it. To find a park or greenway near you, visit OutdoorKnoxville.com. And get out and play, it's good for your health. Mark, tell me about your nose and throat surgery in the office or fixing chronic sinus disease in the office.
5 years or more ago, a company came up with the idea that a balloon could dilate the sinuses and open them. And it's an unusually good place to do that because it's not just soft tissue that you dilate with a balloon. You're actually moving a little bony structure called the uncinate, which is over that osteomeatal unit we talked about. And it will remodel that little bony wall and keep the sinus open. And so over the past 5 years or so, more and more ear, nose, and throat docs are now doing in-office procedures with a balloon to dilate and open the sinuses. And it's transitional. It's really a great time in our field because as we do that, I think more and more physicians are becoming comfortable with the idea of extending what they do to people's sinuses in the office, realizing that with local anesthesia and patients applying the local anesthesia, we can do a lot more than we thought we could, perhaps avoiding general anesthesia in patients and getting the same kind of results and outcome.
When you say local anesthesia, what do you mean?
Well, this is the device that I think has really changed the paradigm. And I brought one before at another show we did, but it's an example of a balloon that we use to dilate the sinuses. And to use this device in the office, I will take little pledgets of cotton, if you will, that have medication, a numbing medication, and a mucosal decongesting, shrinking agent.
So like xylocaine or lidocaine or some sort of cane derivative as a local anesthetic? Is that what you all use?
Correct.
Or some medicine like that? And something to keep it in that area where the surgery won't hurt.
Right, so we'll put the pledgets in there. I'll typically leave them in for about 10 minutes, and then when I take the pledgets out, then I'll usually inject a little traditional lidocaine. But once the patient's topically numb, they don't know that you're injecting them. It is absolutely as if nothing is happening. But that allows us to ensure excellent anesthesia locally. And then we'll take a balloon and we'll put this little balloon tip into the sinus opening, advance the balloon into the opening, and the assistant will inflate the balloon. And as the balloon inflates, it remodels that little bony wall, the uncinate that we were talking about.
When it remodels the uncinate bone, you don't remove the uncinate bone, you remodel it. How long does it stay remodeled?
Indefinitely. It's a little thin eggshell type bone, and you actually can almost hear it crack as it moves medially towards the middle of the nose and opens up the sinus cavity. And once it does that, you can almost be sure that it's going to stay open. And this procedure can be done for the cheek sinuses that we talked about, for the frontal sinuses that we talked about, and for the sphenoid sinuses. It's the weakness of this procedure is you can't do procedure in the ethmoids. And so the people who've pioneered and done tons of these have said, well, you know, maybe I can start doing ethmoid surgery in the office. And with my local anesthesia, as good as it is, and as much as I'm able to move around the nose with the patient not knowing it, many docs are starting now to do ethmoid opening procedures in the office. Patients tolerate it beautifully, and you know.
When I look at the ethmoid sinuses on a CT scan, they look like they're little eggshell little sinuses about pea-shaped. Is it easy to open those up to make it where they're not there anymore?
Right, absolutely. The ethmoids are like a honeycombed space, if you will. And that honeycombing is where the infection will stay put. And if you open a cheek sinus but you don't get the infection out of that little honeycombed air cell, then you probably are going to have a recurrence. And so those patients have traditionally gone to the operating room. More and more guys around the country are starting to use little devices called a shaver to clean out those little honeycomb cells to get the infection out, establish drainage and normal mucus flow. And I think the next 10 years in ENT and sinus surgery is going to be great for the patient.
Is that hard to learn, to be able to do that in the office versus in the operating room where somebody is under control and they're still and you don't have to worry about a wiggle?
Yeah, I think the answer is yes. I think it requires expertise and experience to be able to do it, you know, atraumatically and carefully in patients. And so, you know, it wouldn't be one of the things you'd want to start your practice on, but after you've done lots and lots and lots of endoscopic sinus surgery, I think the transition is pretty easy in the hands of an experienced ear, nose, and throat physician.
Do you have to have a special room in your office? Can you do it in your normal examining room?
You can do it in your normal examining room.
Boy, that's absolutely amazing. Now, You said you can do it in the frontal sinuses, and you can do it in the cheek or the maxillary sinuses, and in the sphenoid sinus in the middle of the head. You do the shavers for the ethmoids. If you establish the new hole, the new drainage area, is there something new to keep that drainage area open?
Yes, in ethmoidectomy, when you do an ethmoid surgery, that's where a lot of people have chronic inflammation, and that's where you see a lot of chronic polyp return. And so, we traditionally have used nasal steroids, but in the people who make polyps, if the polyps advance from the back or the top down and the steroid can't get in the crevices where the polyps are, the polyps just return with a vengeance, and those poor patients have their polyps back and are facing another operation. There's a company that, science is great. One of the wonderful things about medicine is that there are smart people out in our country, engineers, who are coming up with new ways to fix problems and solve problems. And there's a company in California that's come up with a polymer, a device that will dissolve in the body over time, and as it dissolves.
So you put it in there and it goes away.
Correct.
It dissolves.
And as it dissolves, it can deliver different drugs. And so this device, which looks kind of like a Chinese finger caught toy you played with as a kid, is an example of the polymer that is impregnated with the steroid mometasone. It's one of the same steroids we use in nasal sprays in our practice every day.
So you put it in the nose and it opens up, stays there?
Yeah. So
uncomfortable to the patient?
Not at all. And when it goes in, it will actually stent the surgical space open, preventing scar tissue, and deliver steroid into the soft tissue to prevent the polyps from coming back.
Wow.
And this may get rid of the need in many patients for oral prednisone after polyp surgery. And prednisone's a great drug, but it comes at a price. There are side effects that are associated with prednisone utilization, such as bony fractures, bone thinning, diabetes, cataracts, stomach ulceration, you name it.
It can be a bad drug, but some people need it to live, so you have to weigh the risks and benefits. Let's back to the sinus surgery. It looks to me like it's easier and easier to get benefits from surgery. Do you think it will lead us toward more patients getting sinus surgery in the office, or it's still the same algorithm, same plan? You look for underlying causes, you try and treat those, you try and treat medically, and then you go to surgery? Or, it's about time for surgery earlier in the office without the bad problems?
I could see either. I think, medicine and physicians tend to be conservative people, and I think by nature we'll always want to prove that people can't get better on medications. I think with the advent of balloon surgery, it's likely that over time we may pull the trigger a little quicker to do a procedure to open the sinuses up to see if just a few more millimeters of opening gives the patient better comfort, fewer infections, better response to medication. This is such an easy thing to do in the office that I can certainly see this becoming more of a day in and day out tool that we utilize to help patients break their cycle of infection and feel better.
Mark Overholt, this is very, very exciting to me. I think this is a wave of the future. At least it looks that way to me right now. Thank you for coming to the Dr. Bob Show to teach us that sinus surgery doesn't have to be like the old days. There's new things that are easier. It can be done in the office. You're a great teacher.
This is exciting and fun. It's great to be a physician and be in a time in our country where there are so many smart people coming up with great applications to help people out.
Great. Know that if you're going to need sinus surgery, there are some new things that we can do. And now you'll want to stay tuned. We're going to be talking about transient ischemic attacks in the brain, sort of a mini stroke, sort of a quick stroke, here today, gone tomorrow. And women in cancer, what do you need to know? Wouldn't it be great if you never had to see your doctor because you were so healthy? Hello, I'm Dr. Robert Overholt, and I'm here to discuss the governor's initiative for a healthier Tennessee. Remember to be exercising on a regular basis and eat better foods, more fruits, more vegetables, and if you're smoking, stop. I'm Dr. Robert Overholt for a healthier Tennessee. Every year in the United States, there are 30 million sinus infections. Usually they're self-limited. That just means that the body handles that infection without special help. However, if that infection persists, that's the time where we need medical assistance. It may take a CT scan of the sinus to show that chronic sinus infection, and then we treat medically. There are nasal sprays, there are decongestants, there are antibiotics that we use. If that doesn't clear the sinus infection, then sometimes we have to consider surgery. There are new advances all the time in surgery, and now we've been talking about sinuplasty. It's really the newest thing that allows a patient to be able to open up the sinuses without having to go into the operating room. How's it done? Well, it's very simple. Put some medicine in the nose that deadens the nose, and you put the apparatus in the nose, open up the balloon. It opens up the entrance way to the sinus and will keep that open. When the sinuses communicate with the outside, it makes it where they heal much, much better. So know that balloon sinuplasty may be the thing that can keep you out of the operating room and can improve your sinus disease. I want to thank Dr. Mark Overholt. Who would have thought sinus surgery can be done in the office? And now questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob. I'm 48 years of age. I thought I had a stroke. The symptoms went away. My doctor says I have a TIA. TIA means a transient ischemic low blood attack. That can occur in the brain. The brain needs a lot of oxygen. If for some reason that oxygen is taken away for a short period of time, then you can have symptoms of a stroke. What are the symptoms that you could have? Well, one side of the face could draw. So when you ask somebody to smile, the smile goes to one side. Somebody could get weakness of an arm where one arm would fall down. Somebody, when they speak, their speech could get real slurred type speaking. We call that FAST, F-A-S-T. F is the face, the smile, A is the arms, S is the speech, and T means time. If you find somebody with those symptoms, you get to the emergency room quickly. Transient ischemic attacks is a warning sign. 25% of these people go on and have a full-blown stroke. So you need to get your hypertension under control. You need to get your hardening of the arteries under control. You need to be sure that the carotid arteries are not being blocked and there's not bruits in that area. It's an important time to make sure that your treatment is perfect. Question number two, Dr. Bob. I'm 48. I'm afraid of cancer. What should I do? This is a 48-year-old female. Women cancer, the three most common are breast, lung, and colon. Breast is the most common cancer in women. Colon is the most common killer of women. Excuse me, lung is the most common cause of cancer that kills women. So breast, we need to get regular breast exams, regular mammography at age 40, unless you've got a family history. Colon cancer, we need to be sure that we get our flexible colonoscopy or our colonoscopy. That can find polyps that lead into cancer. We start that at age 50 unless there's a family history again. Lung cancer, the leading killer of cancer in women. If you smoke, don't smoke. Stop smoking. It's the best thing that you can do. Those are the three most important things that you can do as far as preventing cancer. But let's think about other women cancers. Let's think about ovarian cancer. Ovarian cancer has vague symptoms, but people do have symptoms. Abdominal bloating, urinary tract irritation, fullness in the abdomen. Nobody finds the cause. Be sure that your OB/GYN doctor is looking carefully for ovarian cancer. Know that people with uterine cancer, bleeding that's irregular from the uterus, out the vagina. Cervical cancer, you need to have regular pap smears. All of those things very, very important to women. Skin cancer, get your skin checked. If you've been out in the sun a lot, be sure that you're not developing little black spots with an irregular border that are growing, sign of melanoma. That's all the time that we have for this show. Remember to be exercising. Exercising is so good for you. Be sure that you do it on a regular basis. It'll make you feel better. It'll keep your weight better. It'll reduce your blood pressure. It does about anything you want it to do. Eat properly. We don't eat properly in the United States. Be sure you eat breakfast. Be sure there's fruit in your breakfast. Be sure as you eat during the day, don't be afraid of snacks. Be sure that they're small snacks. 8 hours of sleep. Sleep is precious. It re-nourishes the whole body. It re-nourishes the brain. It makes us feel better. It makes us perform better. We don't get behind on things. We handle our tasks better. We're happier. We're not irritable. 8 hours of sleep. If you're not sleeping well, talk it over with your doctor. And most of all, what is it that we like in the Dr. Bob Show? It's that laughter in your life. Be sure that you find time to laugh. It will be so good for you and the people around you. Find a person you love. Tell funny stories. Giggle a lot, and you'll stay healthy.